warming up. So we're live now. So if I could welcome you all to this meeting of the Health and Wellbeing Board. There are some welcomes. Firstly, we have Anna Huck, who's joined us following the discussion we had about having a young person's perspective in our deliberations. I met with Anna and was able to discover a great deal about her, and she seems an absolutely first-class person to be discharging these responsibilities. I learned that she attended the Harris Academy and that she got involved with the Youth Parliament at the age of 13 or 14. So she's been, involved in this kind of stuff for a long time. So don't let her youthful appearance kid you. She's learned a lot in that time, and she's also doing a degree in criminology and psychology, and so this is a kind of part-time role for her, but you're very welcome and we hope you enjoy it. And then I'd also like to welcome our new committee clerk, who's Jade Watts, who's joined us from the London Borough of Croydon, and this is her first meeting with us, so I think it's important that we extend a very warm welcome to you as well. Would it be helpful if we very briefly introduced ourselves so that everyone's aware? I'm Peter McCabe, I'm the chair of the Health and Wellbeing Board. Jennifer, would you like to go next? And then we'll go that way.
Councillor Jennifer Gould, lead for health, the main, sorry, for the Liberal Democrats, thank you.
Brenda, can you put your mic on? Sorry.
Councillor Brenda Fraser, Cabinet Member for Children's Services.
Hi, I'm Mark Krillman. I'm the Place Executive for Merton at the Integrated Care Board, the ICB.
Hi, I'm Dr. Simonton Gannis-Ratnam. I'm a local Merton GP, Merton Primary Care Provider Representative and Vice Chair.
Hi everyone, I'm John Morgan, and this is the first time I'm using this title, so I might get it a wee bit wrong. I'm the Executive Director, Adult Social Care, Integrated Health and Public Health.
And I publicly thank John on his appointment. We've worked for some time together, but I'm delighted that he's taking up this role on a permanent basis.
Hi, good evening. I'm Dagmar Zorn. I'm Director of Public Health here in the Council.
Hi, Keith Burns, Interim Assistant Director for Commissioning in Adult Social Care, Integrated Care and Public Health.
Hi, I'm Clarissa, Partnership Manager for the Health and Wellbeing Board.
Nice to meet you, everyone. So I'm Anna. I'm a young inspector at Merton for the past 4 years. I primarily work for public health. I do a lot of work on the Under-18 COVID Champions Group, the Peer Educator Project, Youth Mental Health, My Health, and social prescribing as well. So it's lovely to meet you guys. Thank you.
Hi, I'm Sukpal. I'm the Participation and Engagement Manager at Merton.
Hello, I'm Jo McSherry. I'm the Executive Director for Children, Lifelong Learning and Families in Merton.
Hello, I'm Graham Terry. I'm the Interim AD for Adult Social Care Operations in John's Directorate.
Are there any declarations of pecuniary interest? No, that's good. Yes, we haven't done apologies. There are apologies for absence from Adrian Ash, and Sarah Goad. So are there any other apologies that people are aware of or been asked to convey? Okay, those are noted. And the minutes of the meeting held on the 29th of November have been circulated. Are they agreed? Great. And then I'll sign those. And then the next item is the Merton Safeguarding Adults and Children's Partnership. And I think, John, you're going to introduce this and then there'll be others to follow.
So we've been very, very lucky in Merton, because for the last few years, we've had a very experienced independent chair to both our Adult Safeguarding Board and our Children's Merton Safeguarding Children's Partnership. And her name is Eileen Buckton. Unfortunately, Eileen has been ill since before the summer, and we're unsure when she's going to be coming back. For interim arrangements, I stepped in to be the chair of the Adults Board, and for the Children's Partnership, they've had a rotation of different chairs from across the partnership. But we really wanted to get some stability back into our safeguarding, as well as some independence. We went out to the Southwest London chairs of safeguarding boards to see if anyone would be interested. And Nicola Brownjohn, who's currently the interim chair in Kingston, independent chair, sorry, in Kingston, expressed an interest, and we've met with her and agreed that she will be our interim chair until Aileen is able to return to work. The only other thing I just wanted to say before I pass you across to Jane and Graham, we're presenting both of our papers tonight, both of our independent reports tonight. The adults and the children's reports are coming together. And we think that's really important because it shows the work that we do together as two directorates, with children's transitioning into adults and then adults, of course, as well. So I'll pass you across to Jane first and then Graham.
Yes, we can do it that round. Thank you, John. Chair, I think also we've got our Safeguarding Board managers should be joining us online. So I saw Janet a minute ago, but Maisie also, I think, yes, Maisie is also there. So obviously when we get into the questions, they will have the detailed answers to some of those questions. So just as a bit of context in terms of the Safeguarding Children's Partnership, so Working Together 2018 requires each local authority to establish arrangements for safeguarding and promoting the welfare of children, and that is fulfilled in Merton by the Merton Safeguarding Children Partnership. And the partnership has an executive group. So in terms of children's safeguarding partnership arrangements, the three executive partners are the local authority, the police, and health. And then sitting underneath that, we have a wider safeguarding partnership that includes a broad range of partners and also a set of subgroups, as you will see within the report. The Working Together guidance also highlights the importance of liaising and sharing reports with other local strategic partnerships, such as the Health and Wellbeing Board. And we really welcome bringing the report alongside our colleagues in adults as part of our more joined up working that we have been establishing over the last few years. So during the reporting period for the annual report for the Safeguarding Children's Partnership, which is April 21 to March 22, Merton's strong safeguarding partnerships were acknowledged in our external ILACS Ofsted inspection of children's services, which took place within that time frame, although it wasn't published until the following May. But the Ofsted report highlighted in some detail the strength and robustness of partnership working in Merton for safeguarding children. The partnership embeds learning throughout. Examples include delivery of the local child safeguarding practice reviews, multi-agency audits, and delivery of a comprehensive training programme. And we are working alongside colleagues in the Merton Safeguarding Adults Board to strengthen our joint working. We delivered a joint conference last year and we'll be delivering another joint conference this year on the 15th of March, which will have a focus on domestic abuse and the lived experience of trauma from child to adult. I'm just going to pause there to see if Maisie wanted to add anything else in the introduction to the children's report.
No, thank you, Jane. That's fine.
So I'll pass to Greg.
Okay. Thank you. In terms of the Merton Safeguarding and Adults Board annual report, there's a similar requirement under, I think, Section 43 of the 2014 Care Act to submit a report to the Health and Wellbeing Board. And in previous weeks, this has gone to the overview and scrutiny as well. The Merton Safeguarding Adults Board is responsible for ensuring that systems, policies and procedures in Merton are effective and keep adults safe. The annual report sets out a wealth of activity during the reporting period, April 21 to March 22. It actually covers a period that's obviously a little a year old in many respects, and that's part of the requirement that we have to report. The actual report itself, if you've studied it in any detail, shows some updated information about activity and some of the things that have happened since 21-22. Clearly, as Jane was saying, working jointly with our colleagues in children's services has been a key focus to strengthen that partnership working and the experience that people, young people, and through transition into adulthood have of feeling safe and protected. And obviously, sharing an independent chair with the Safeguarding Children's Partnership can only support joint working. There's also a more joined up approach being embedded, which Jane's mentioned in terms of the joint conference delivered in March 22, focusing on think, family and transition. And those have been two really key things for adult social care to focus on in terms of our practice. But it's enabled us to bring together leaders and practitioners across adults and children for those learning events, and that's encouraged and promoted those relationships and the ability to share learning and stronger engagement with partners and more joined up working. I'll pause there and see if Janet wants to add anything to that introduction.
Hello. No, I think that's fine, Graham. I think you've covered most of it. Thank you.
So, are there any questions, comments from members of the board? Mark.
As you'd expect, mine's probably a health question. I know we're a partner, and that's fantastic, and I fully appreciate the great work that partnerships do. I wonder, just in terms of general health, though, are we kind of maximizing, because many of these are our most vulnerable people, and we know that our most vulnerable people have the poorer health outcomes. So it's just whether there's further work we can do to kind of make inroads into that kind of making every contact count kind of thing.
So I'll start off and then Maisie might want to come in. So we have a subgroup that specifically looks at early help, that sort of intervention, early help and prevention, and obviously there are health partners on that subgroup, and the real focus of that would be to be trying to put in the support we need at a sort of universal level, at a targeted level, before obviously before children need to access statutory services. So it is a real it's been a real focus of the piece of work in the last year, that we've, in terms of the early help subgroup, has launched our early help strategy and effective support for families. And that very much is about how we respond to needs at a sort of targeted early help level prior to hitting statutory services. And there was an early help summit in November 2021, which was chaired by our independent person. And then there's work that's proceeded from that. But Maisie may want to offer further comments, because obviously we do take every opportunity in our learning reviews to also reflect if there's things we could have done earlier.
Thank you, Jane. Yeah, I would agree that it's been a key focus around sort of embedding and strengthening our early help, particularly our effective support model for families. What I would say is that we've had really strong participation from health partners, from a range of health partners, in fact, within the subgroups, including the early help subgroup, which is really, really positive. In terms of learning reviews, you know, we've outlined some of the themes that come up in the report, and I think it's a really important part of what we do. Within the work of the quality assurance subgroup, we're sort of taking forward a number of recommendations in response to those learning reviews as well. And we've also, in this reporting period, we also kind of reintroduced a modest audit programme as well, so that we can really monitor any kind of key themes that come up as part of the work we do. So we can certainly kind of have a think about that, Mark, and sort of think about if there's anything further we want to do and where we might do that in the partnership. Thank you.
Just in terms of adults, there has been a real focus okay. In terms of adults, there's been a real focus on looking to engage people with lived experience. And there's also a real focus on developing community champions and enabling a whole variety of people to comment, feed into how we safeguard adults. And we also look at the outcomes that whether we have reduced the level of risk to individuals. And that's done in conjunction with similarly a whole range of partners on the Safeguarding Adults Board, including health colleagues. And I'll pass over to Janet in terms of any specific task groups, or John.
If I can come in first, and then Janet, of course. I mean,
Thank you.
we've got 4 subgroups to this Adult Safeguarding Board as well. And we've got really good partnership and engagement from across the whole system, from the ICB, our CLCH, our community health provider. The thing that we do need to have that we don't currently have is a more, I mean, I'll be careful with the language, but I will say strategic group, a senior strategic group with the chief executive of the ICB, the police, etc., so that those people are better sighted with our own chief executive of safeguarding across children's and adults, so that it isn't, you know, the really people at the highest level know what's happening with safeguarding in Merton. Now I'll pass you over to Janet now.
Thanks, John. So I just really wanted to highlight the work that we've started with public health around people with lived experience, particularly those experienced in alcohol and substance misuse. So that's something that it's kind of just got off the ground, and you know that will help us to work closely with public health, but also to a two-pronged attack, I guess, in terms of hearing the voices for the Safeguarding Board, but also for public health around people with those difficulties. So yeah, and also the SARS that we've had, the Safeguarding Adult Reviews, in terms of the learning. This work in terms of public health has come from one of those reviews, and that's ongoing. And SARS, I guess SARS across the board, we're looking at the learning from SARS, and it's helped us even forge closer working relationships, I would say, with children's services around some of the systems and processes that we use in terms of making sure we got it right for people. So yeah, that's from me.
I hope that answers your question, Mark. Okay, well, I haven't seen any other people wanting to ask questions or speak. So we've got two recommendations on page 5 of the printed agenda. Are they agreed? These are recommendations A and B. They agree? Thank you. Right, so item 5 is the joint strategic needs assessment. And Dagmar, you're going to introduce this with some.
Yes, thank you very much, colleagues. There is a rather big report in your pack. And what I thought is I've pulled together a few slides to make it slightly easier for you to digest. The report asks you, just so that we all know what we're doing, to consider the Merton story. You will obviously be aware it's a statutory requirement of this board. And then particularly with a view of how can it help us to inform priorities as we are going forward. And then if you are satisfied to agree the story for publication and dissemination. So hopefully just whizzing through a few slides. Reminder is that the Merton story, as I said, really is a tool. And it is high level. There's already quite a lot, but the biggest challenge in a way is filtering out what is strategic. Quite important to understand is that this is a profile of health and well-being. It is not in-depth service reviews or indeed recommendations for service changes. There are other fora and means to deal with that. And just if you then ask me, well, how on earth did you filter all this data and in a way tame it a bit? So in terms of methodology, we are lucky. We've got a very comprehensive public health outcomes framework. Now that's a tome and it's dense, but it's rich. So that is our, in a way, epidemiological background. And then we are triangulating that with we had a big stakeholder group, service leads across the council, across the different council teams, but also very much with our health partners and our voluntary sector who are all here on the board to say, well, does that make sense? What matters to you? And so pulling those from in a way from the data and then from how it works at the real co-phase, we tried to distill some key messages. And in terms of conclusions for further work, so that is what we this time have added, not just giving you some headline messages, but in pushing a bit more and say, what does that mean for the Health and Wellbeing Board? Generally, in special educational need and disability required extra work because pulling strategically data together doesn't allow necessarily to go into depth, but that was an area I think we all agreed needed more work, and Jane has already mentioned the recent successful inspection. Substance misuse, you've heard again, it was mentioned through the SAR, is another area where we're going to focus more in depth. And then I will present you later my annual public health report, which also gives you more information around health core benefits from climate. We also have ambitions, and again, going forward as a Health and Wellbeing Board with our Merton Health and Care Together partnership, how we embed making the JSNA really, really useful. We want to use more of the healthcare data. I'm looking to my colleagues on the right. The ICB has got quite a rich insight data platform. And Sai is very versed in data and intelligence. So with a bit more in pulling together, I think we could increase our understanding. So if we move us on, so hopefully that just gives you a little understanding of our attempts to understand our population. So the structure is, we look first at the population, then you will see we will have a little bit about COVID, and then we follow our well-versed structure about start well, live well, age well in a healthy place. So in terms of population, I won't go through all the details, but in the middle bit is what we call our population pyramid. And that shows you the age distribution that we have now, and then the dotted lines are the age distributions in the future. So this is a summary of our projections. And not surprisingly, like anywhere else, our population is aging and birth rates are actually falling. Now, that is really important if we want to plan services. What does that mean? I always say, don't jump to conclusions like, oh my God, it's all bad. I feel all our population, that is our asset, and many older people are in good health and full of expertise. And so changing that frame a bit from saying, oh my God, our population is aging, it's also an opportunity. Now, well known for Merton is that we've got big east-west differences. I've also given you, because east-west is not necessarily a well-recognized geography, I've given you deciles and one well-evidenced measure of inequalities, health inequalities, is the discrepancy between the 10th worst off and best off in terms of life expectancy, and the gaps are 7.7 years for men and 5 for women. And on the right-hand side, you see we haven't really made any improvement. If anything, that's getting worse. So here we are as health and wellbeing board leaders. That is something to never let out. I think, Chair, you've made that very clear when you took the board, that will continue to be a focus. Also remembering, and because we need to consider it, I think, in the future, our NHS partners are very committed now to play their role in reducing inequalities. It is a very complex long-term endeavour. And there is a methodology called Core 20+5. Sounds a bit technical, but actually chimes with what we have done. The Core 20 are the 20% most deprived. So that when we look at data, that we really ask ourselves, who are these, and are we inclusive? Are we looking at the least well-off as well as everybody else? So bit of flair on the population, if we move us on. The next one is COVID, and I'm sure you're thinking, oh no, nobody wants to think about COVID, but we have to. We're lucky in a way, the headline is, and it still stands. Looks like the pandemic is on the retreat. That is vaccination as well as natural immunity. But there is a lot of fallout from the pandemic. And I think what we are now really learning is how compounded that is with the cost of living. So we are not now walking into the sunset. We're coming out of a pandemic into a cost of living crisis. What is also important to consider about the pandemic is that particularly children and young people, and I'm delighted that Anna is here, have taken a brunt that we probably, while we were in it, were not quite considering, as the direct health impacts for children and young people were modest compared to older people, but the long-term impact and some of the measures that we've taken, children took the brunt. So there is work for us to do now to remedy that. And so in terms of conclusion, we in the background, meaning me, my public health team, are still very much keeping an eye, living safely and fairly with COVID. You will have heard China has got lots. There's always talk about some variants. There was one in the US. Not taking it for granted. Vaccination are absolutely our mainstay, so we can't stop promoting, although people say you are a broken record. I don't mind, and I need anybody and everybody to help with that. Long COVID hasn't gone away for those who suffer it. It's not in the limelight anymore, doesn't make it any better. So we've got a responsibility to continue to support and learn. Research is still underway. And then for me, there is something although we all want to forget, not to forget what we've learned in the pandemic. There is some quite amazing coming together of people and energizing community support, solution-focused partnership working, our community champions. So I'm very, very keen that those good things we hang on to. So if we move on, I'm now going through the life stages, and I probably need to speed up a little bit. So always starts with actually, generally, let's not forget our children have a good start. If you're born in Merton, most kids have a good start, but not everybody. And it's our duty to particularly look after and care for those who haven't. As I said, the pandemic has hit children and young people harder, and I've listed here mental health issue, disordered eating, healthy weight, school readiness for the little ones, attainment, school absences. There are quite a number of issues, and all of it that obviously now compounded by the cost of living crisis. Going forward, you've heard already a lot of work is happening in partnership around SEND, and we're now moving from not only understanding the data, but really focusing what are the joint up strategies to support people, to support children, young people and their family with special educational needs. Mental health is a big one, and I think Anna can help us a lot. What do holistic mental health support actually mean for young people? There is a whole new phenomenon out there, which is clumsily labeled disordered eating. It is not quite reaching the threshold of an eating disorder, but something isn't right, and we have a lot of admissions. And it is linked. There is food poverty, there's unhealthy weight, there's disordered eating. There is a whole new complex issue that I think jointly we are pretty well placed to get our teeth into, understand it and offer help. A few specifics have been highlighted. It again, Anna will be able to help us with that. Increasing vaping in children and young people, and particularly there's sort of the commercial exploitation that goes with that. How do we deal with it? For adults, vaping, for smoking adults, I should say, vaping is an acknowledged evidence-based means of getting off the smoking. But for children and young people to start vaping is not. So how can we work with our young people to get to the bottom of that? As I mentioned, school absence is a big issue. And then as we're also talking about a healthy place, air pollution, particularly around schools, is a real issue. And I think Merton has made great strides already with the school streets. If we move on. The big message in Live Well hasn't changed. It hasn't gone away. So we need to rethink how we indent it. There are loads of people, and I mean large numbers of people with public health risk factors. They are the old ones, nothing new and exciting. Unhealthy diet, lack of physical activity, smoking, and alcohol misuse, underpinned by emotional and mental sort of mild to moderate distress. There are, as I said, compounded by environmental risk factors now, particularly air pollution. These are all preventable factors. They all contribute big chunks to the burden of our chronic diseases. That hasn't gone away. And if you look at it, and we call ourselves Health and Wellbeing Board, there is a call for us all to think, how can we embed prevention? How can we be the guardian of preventative action, particularly in times when the money is so tight? So again, for us as a Health and Wellbeing Board, I think that is one of the really challenging leadership questions we have to find our way through. And again, in my annual public health report in a minute, there are other ways how we can try to do it, and the health core benefits of climate action fall into that category. Other things, and health partners are very aware, this board has discussed a lot, but we need to push further, is equitable access to community and primary care in particular. So lots to do there. If we move us on to Age Well. The big message in Age Well, and it won't come to any surprise for anybody who works at the front line, is the increasing complexity of what people come and present with. And so it's the whole range of many physical diseases coming together, what we call comorbidity, overlaid by mental health issues, often dementia, thrown in some substance misuse, difficult social circumstances, sensory impairment, frailty, loneliness. There is very quickly, you have a very complex set of needs, and managing and supporting people through that taxes us all and taxes us particularly as a partnership. But I think the only way to find appropriate support is through putting the efforts of all the partners together, including carers. Very important. A lot of the burden of that work falls on informal carers. Voluntary sector does a brilliant job. So we need to think about them as part and parcel of any of the solutions that we design. My colleagues from adult social care particularly also rightly said you must put the health and well-being of people living with learning disabilities in there. Some of the most complex cases we've encountered, and often still, unfortunately, missing out, particularly on some of the preventative services. So a call to focus and do better. Finally, healthy place. If I get the last slide, overarching message is Merton is really rich in assets, be it green spaces, be it civic pride, social activity, history, cultural history, history of sport, our libraries. So there is a lot that's happening, but there's also the other side of the coin. There are neighborhoods that are environmentally vulnerable, air pollution, neglect. So developing Merton as a whole healthy place, and working with our colleagues in environment and regeneration on the climate action, which is a big priority. Pulling our efforts together will bring lots of benefits for health. More and ambitious plans for the libraries. There are really a lot more than libraries in Merton. They're community assets, community spaces. And you will have heard as a board, I sneak it in, Actively Merton is one of our big attempts to scale up physical activity offer, social activity offer, but really importantly as well, the way people want it. Not prescribed as a sort of disgusting medicine, but offered as something that's fun and builds on the ingenuity and resilience of our communities. So hopefully that gives you a bit of an overview. There is a lot in the report. There's also a link to a big reference document. So if you pick some numbers and you want to know where do they come from, then hopefully you find it there. Thank you.
Thank you, Dagmar. Are there any questions? I've got two hands going up almost simultaneously. I think I will. Brenda.
Thank you, Chair. Thanks, Dagmar. That's quite a comprehensive work. It's actually to be settled later on because it's a lot to be taken in. I have a few questions. Long COVID, how is the data being gathered? How do we know how accurate this data is? Because the reason I'm saying that, I have met a few people who tell me they've got long COVID. And in fact, these are young people even, and they won't come out of their houses. So they're not socializing with anybody, they're not working, and it's complex because it covers everything. So that's one. And if I give you another one before I let us free to answer, vaping is something that's bothering me because of young people and smoking. The shops are all over the place. And there is one in my ward that I have complained about because it opened into a little box almost. And in that place, they're selling sweets and lollipops and all sorts. And from what I understand, I've not been in it, that sometimes the ice lollies that they sell is actually part of the vaping. So I don't know how true that is. Is there any way that we are keeping in touch with these people to make sure they're towing the line, please? And I'll come back later. Thank you.
We'll take the question from Councillor Gould now, and then you can answer the two if that's okay.
Mine was similar to do with the long COVID, actually. You mentioned about research. I just wondered what, if any, research was taking place in Merton particularly. Also, you mentioned about carers taking the burden. Carers as part and parcel of the solution. I'm just wondering what respite care is available in Merton for carers as going forward. I think that's something that is going to be really important. Thank you very much.
Thanks very much. So if I come to long COVID first, and your question around data, because obviously the Merton story, it's data and information. So what have we got? There are two big sources of understanding long COVID. One is the ONS study. So there's a big national study that actually counts. And we then, from a sample, apply that to the Merton population so that we have a rough estimate of how many people with long COVID we expect. And obviously that chimes as well because we know how many infections we had, and then we know roughly how the infections translate into long COVID. So that's in a way what we expect is out there. And then there's the other side, and I will hand over to my frontline clinician. There's people who come into contact with the health service with the symptoms of long COVID. There's actually a huge discrepancy. So we think there are probably a number of people battling with long COVID on their own. And sometimes, because there has been quite a lot of qualitative research as well to understand how people deal with long COVID. Some think it's just part and parcel and I have to bite my way through. Some feel almost ashamed and don't even want to talk about it because they feel it's a failure and it looks like if I'm, drawing it out or malingering. There are all sorts of shades. And as you can imagine, in a diverse population, there are different experiences of long COVID. So what we're trying to do is to bring the two closer together. Yeah, so that we say we assume there is quite a lot of need out there that is not properly met. So, for example, with our community champions, we had a really comprehensive session around long COVID and have then equipped them with access to services, yeah, to say, where could you go? And if I possibly, if that's okay, Chair, hand over to Sai just to see your end of the stick.
Thank you, Dagmar. And this is really quite complex. We know that the pickup rates for people with long COVID is underrepresented in deprived and BME populations. So we realise that people aren't coming forward. My experience is that often they don't know how to access the resources that are out there. They need a huge amount of extra support. In primary care, we are utilising roles such as health and wellbeing coaches and care coordinators to signpost people and support people. In terms of NHS services, there is a post-COVID, long COVID service provided by Central London Community Healthcare across Merton and Wandsworth. That's very much focused on those who are most severely impacted by COVID. So it's very much a specialised service, alongside which there are sort of digital support measures that are available online. But one must acknowledge that there are only finite resources and there is not enough out there to meet the needs and demands of local people. So we have to do the best we can, and we need to raise awareness and we need to reach out and engage with those communities.
Have we got any sort of papers that we distribute? Because I'm, sorry, as I was saying, in my ward, I know of people, but they are, I can access them, but probably you wouldn't even know them. And so if we have leaflets that we can give them, so at least they can read, see what's happening, because it's all right to talk about that, we've got it, but who is getting it?
So I can probably answer that one. So South West London does have a long COVID group, that basically looks at this. So I can take that request back, Councillor Fraser. Interestingly, the long COVID service that Si mentioned is actually a topic for the next OSC meeting, and Mike Proctor from my team is doing a presentation there, which I'll happily circulate, and all the caveats about the data as well. But actually, I'm looking at a slide that says 4,211 Merton residents are estimated to be living with long COVID. So I just wanted to throw that into the mix, but I'll certainly take that back to Mike and the South West London group.
I think it would be helpful to circulate that when it's available, Mark, please. Thank you.
Shall I pick up, because there were another few bits? So on the long COVID research, there's masses going on. I am not completely cited which bits of Merton contribute to what study, but the whole breadth, just to give you a flavour, we're not really sure about the natural history. So there are some studies that have enrolled people with long COVID and they just follow them up to see what's actually happening. How quickly is it resolving? Is it resolving? What is it leaving behind? There are some studies that are very organ specific because it's such a broad spectrum, but at the very severe end, you can have cardiac disease, respiratory disease, you can be left with organ damage. So there are specific specialist studies. First of all, services looking after those people, but also trying to understand, well, is it going to heal again or not? And then there is what I call the softer end, but it might not be experienced as soft, but where people just generally struggle, it's fatigue, it's brain fog, it's not really functioning. And quite a lot of that research tries to look at interventions. Rather than clinical intervention, it might be more of a social support interventions, so helping with caring. That was one of the big stresses, even, picking up the kids from school, supervising the homework, the fatigue, so that you think, what could actually help? It doesn't need a clinician, it needs some support. And working with WDP, because losing a job and then finding another job when you feel groggy is a really tricky one. So first of all, helping people not to lose a job if at all possible, supporting them through, and then working with some adaptations. So if they need a break, for example, in midday, that they can pick up, if the work is flexible enough that they can pick up work. So a whole variety is underway. And what for me is quite important is that we push that is seen through, because, you know, the limelight was on, and for a few, you know, a bit of time, everybody was talking about it. The people are still suffering, but the world has moved on. And that's where I think we have to come in. And that's why I wanted to anchor it in our Merton story. Quickly to vaping. Vaping, I'm a German here. Obviously, enforcement is one of the means. Selling vaping products to the under 18s is illegal. But I think enforcement is important, and obviously we're working with enforcement, but there is more in terms of what we can do in terms of understanding, and particularly working with young people to get a bit more to the root of what is so attractive, why are people doing it, what's their understanding. And I'm really keen that we first of all listen. We need to do quite a bit of listening. Anna, do you want to come in at all, if I may, Chair?
100%. Just to allude to your and your priorities that you've mentioned, a lot of it links together. So I do think it's important to look at things from an outside perspective, but then zoom in on individual factors to see how it obviously influences each other. So obviously substance misuse links with mental health. And for example, that could lead on to asthma. So obviously everything links together. And I think, especially when we, you know, work with young people, it's important to look at individually between the young people, but also to look at them as a group to see how obviously the individual influences the group of young people, and how obviously young people influence each other. So I do think when it comes to, for example, vaping, it's important to have a very flexible approach when we, you know, look at things and really look at things from, you know, as I said, the outsider perspective, but zoom in on the key priorities that are there, but also to see obviously the long-term impact, what, you know, Dagmar was alluding to, because at the end of the day, during the COVID recovery phase, and especially the work we've done in public health and participation, we've seen that, you know, individually and in terms of group of young people, COVID has had, you know, different types of long-term implications on obviously, you know, how young people feel, you know, the health, you know, impacts that, you know, they deal on a day-to-day basis. Because sometimes, you know, health can mean, you know, they for example, struggle within themselves. So for example, mental health, and they don't necessarily talk about things, for example. So for example, vaping could be an aspect where, you know, a young person could, you know, do it personally. They wouldn't talk to their friends, for example. So I think, you know, that kind of approach of flexibility is important, you know, especially as I said, when it comes to vaping, because, you know, with a young person, you know, there's no one approach that we should always focus on. So yeah, as Dagmar was alluding to, you know, COVID has impacted us in a lot of different ways, if it's adults, young people, you know, and yeah, so just to kind of, you know, yeah.
Thank you.
No worries.
I think there was one other quick one. It was around carers. Oh, did you want to come in first? Your point around carers and what is on offer for carers. This is precisely why I put it in the Merton story, which is the description of the need in a way. I have absolutely not aspired to describe all the services, because that's outside of the remit, but I want us to always loop back to the carers and the importance of carers. So if I describe the burden of disease, and then we talk about what health and care services we have, I want us to also always say, and what about the carers? But obviously I'm surrounded by colleagues from adult social care and also health. So you might want to comment briefly on some of our carer support, particularly respite. I think it was mentioned.
Mark has indicated that he wants to speak, but maybe John.
Maybe Graham or.
Sorry, I was going to ask John to comment on the respite care if in Merton specifically, and then we'll come to Mark.
We do currently have a joint carers strategy with health and across our partners. It's really important to us. Carers do a fantastic job. It's really important to us to work with our carers. We are looking at our carers strategy offer just now as well, what we give people for learning disability. And Mark might be able to add to that.
So I think also just in terms of our local health and care plan, we've talked about supporting carers more and making sure that it's really joined up across health and social care. And I think so it's a work in progress really, because there's always so much more you could be doing with carers. So I think it's one area that we want to develop even further. Can I make my general comment at the same time, just in terms of the...
Please do.
So Dagmar, it's really powerful data, isn't it? It's really, and actually it's you mentioned our core 20+5, and I think probably I would propose that, because that's a health kind of a health population health management tool, that perhaps we bring that back to the Health and Wellbeing Board, because I think as you put these strands of data together, it picks up on Anna's point. The individual is really key, and it's about getting down into very small interventions in particular roads or particular areas, and that's where we need to, as a Health and Wellbeing Board and a partnership, really try to kind of hone in, as you were saying, on the individual. And I think it's really sad, isn't it? It's really sad that when we look at the maps, we have that geographical split. And, you know, 43% of obesity in one part of the borough, which just fills my heart with sadness, really. And the other thing that I just wanted to mention was the importance of vaccinations, the importance of immunizations and vaccinations. Sai was talking to me earlier about actually flu. You know, there's just there's so many people with flu in our hospitals, in our primary care. And with the vaccination, we can protect those people. So it was just, a sort of call to arms to do something about our geographical inequalities.
I'm conscious that we've got an awful lot on the agenda tonight, and we can't spend the entire evening on this particular item. So if you could make it brief, please, Brenda.
Thank you. I was just thinking, when we mentioned carers, it seems as if we've homed in on carers as family, but there is the larger carers that goes out to see people because through an agency or wherever they go from, most of them are paid pennies to do what they have to do in a very short time. And so therefore we need to look at the wider picture of carers. Family, okay, they might not consider themselves carers anyway, and don't even want money or anything else for it, but they still need respite and care. But we need to look at the other side of caring, which we haven't mentioned at all.
So, for paid carers, we are just in the process of re-looking at our contracts. It's a huge amount of money we spend on adult social care and carers to keep people at home. I think it's 10 or 12 million a year. And we're going to be recommissioning that service over the next year, and looking at paying the London living wage for those people that do a fantastic job. To know the whole health and care system would collapse without paid carers. We want to pay them London living wage so that they actually get paid a bit better for the great work that they do.
I think I'll draw your attention to the recommendations on this, which are recommendations A and B on page 57, or if you're looking at it on your laptop, it's page 61. Can we agree those recommendations? If you all say agreed, that is helpful. Thank you. Okay, so we now move on to agenda item 6, which is the annual public health report, and Dagmar is going to introduce.
Yeah, sorry that you have to hear me 2 in a row.
We want to get our money's worth.
Good. Okay, I will give it to you. So thank you very much. Again, draw your attention right at the beginning. Purpose to bring it here is for you to endorse it. It's my independent annual public health report, so I've got a statutory duty. And then obviously I want you to consider the opportunities. I write my annual public health reports not with a list of long recommendations, because I feel we've got other fora where recommendations will be followed up, but I've listed opportunities, and I want to draw the attention to those opportunities, hopefully relevant for this board and our Merton partnerships. I've got just 3 slides you will be relieved to hear. Again, to help you navigate, I hope you managed to cast an eye on the report. So first of all, as a reminder, it's my statutory duty. And the way I tend to develop the themes of these reports is not to do it just in a darkened room, me and my laptop. I try really to sense check quite in advance with partners. How could I add some value with some more in-depth? And for quite a long time, climate and health has been going around as a topic. And finally, we really honed it down. So I have not written you a comprehensive report about all the health impacts of climate change. There are myriads, and we're experiencing them mainly due to extreme weathers. That is a given, and I've referenced where you can find them, but I have honed on the core benefits for health that climate action can bring, with a premise in a way that I don't think we sweat them enough, and we are calling ourselves a health and well-being board. So there are partners out there that are doing lots of things with health impacts. If we nudge them even a bit more and work with them, the health impacts could be even bigger. So it is an opportunity, and I find it, I wanted to write it because it's a particular opportunity now as we're strengthening our place partnership. That's just quite important, because if people read it quickly, they think, oh, it's another report about climate change and health. And so the purpose of the report is that I show you the scale of some of these health core benefits, because you might think, oh, well, a little bit here, a little bit there. It's big stuff, so it's worth pursuing. I want you to remind you, and Chair, in your first Health and Wellbeing Board, we endorsed a health in all policies approach as a framework for this board. Maximizing health co-benefits of climate action is precisely fitting into that framework, because remember, when we said health in all policies, we are now saying health, sustainability, and equity. Those 3 are hanging together so closely, we have to do all 3. And if you think about it, healthy people cannot really be healthy if they don't have a healthy planet. So action to create a healthy planet are good for the people, and action to make people healthy often are good for the planet. There is a marriage that I think we need to strengthen a bit. Maybe that was not a very good metaphor. And very importantly, again, a big opportunity is that the Council is very strong on its sustainability credentials. It has done a lot of work. It's one of their priorities. So now with health all lined up, and the NHS also now saying, we need to do something, the stars are aligning to give this a push. So you hear I'm quite excited. It was quite fun to spend a bit of time to pull this together. There are 6 themes that we feel are particularly important. One is active travel. One is healthy and sustainable diets. And you now already see they have a sustainability angle and a health angle. Yeah. Accessible, biodiverse green spaces, good green jobs, not just good jobs, not just green jobs, good green jobs, energy efficient, healthy housing, green health and social care. If you give me the next slide, we've tried to condense it all in 10 key messages. The 4 key messages are in the report. But the story for you as well to hold on to is climate change is awful for health. You know, we had 3,000 additional deaths in this country the last summer. Are you aware of that? Imagine 3,000. What if you know, a bomb goes down or something like that? 3,000. Have you heard many whispers about that? People thought, oh, it's almost like the Caribbean. You know, I have got my drink in the evening. Not if you were in Mitcham, frying in some of those houses where you could hardly sleep, speak, sweat. Everybody then cramped into the rooms downstairs because the loft is unbelievable. No, it is quite brutal. It is brutal now in this country. It's not just somewhere else in Australia, it's here. So the direct impacts are horrible and only there to become more horrible. And so you get all, you could get all despondent. But that's why we need our climate teams, and they do brilliant jobs. And they say, we have to reduce these greenhouse gases because otherwise the heat will go even worse. So they help us with the direct health impacts. But I'm on the more positive angle as well, because while you are fighting for climate, you, in a way, as a collateral, improve public health risk factors. And the main ones, and once you look at them, the penny drops quickly. The main ones are air pollution. You know, air pollution, it's really killing people. The figures I've given you, you know, we can put contributed death against air pollution. The other one is physical activity. You just before heard me in the Merton story saying lack of physical activity contributes to the burden of disease big time. And we have big numbers of people who are lacking physical activity. Wow, if we're now working for climate action, let's not just decarbonize our travel, let's push active travel, because then we get the weight down, we get the health benefits, and we get the benefits for the climate. So air quality, increased physical activity, healthier diets. We don't want just a crappy meat substitute that is even more unhealthy and saying we've done our bit for the planet. No. You know, the opportunity is there. If we have to change diets, and it's a tricky thing, it's an emotive thing, then please let's think health. And then finally, better mental health. That is often underestimated, but in green spaces, for example, and Merton is endowed with loads, is so important for mental health and well-being. And if we then think, what can we do with our green spaces? Huge opportunities. So hopefully I fired you up. Last slide. Digs down a little bit more. If you move us on, Clarissa. Is it stuck? Anyway, you find it in the report as well. The last chapter is around opportunities. And the main message there as well is we can actually be quite proud because we've got good foundations to build on, but there's always more we can do. And what I want us as a health and wellbeing board with our Merton Health and Care together to really start to think through how we can combine and do a bit more integrated planning so that when the climate team talks about reducing carbon in transport, we can also say, yes, that is the opportunity for active travel. That helps our health colleagues a lot. You know, people with cardiovascular disease, with diabetes, they're so much better off if they move around. Let's put our energy together. And the NHS really keen on active travel. We've got lots of staff who could really be exemplars for active travel. So using the opportunity of integrated planning at place is one of the exciting, I think, opportunities I hope we can grasp. And I'm delighted that Anna is here. The planet, really, we're messing it up for the youngsters. That we cannot have. So engaging young people and developing them as place leaders so that they feel and have a voice and help us to make the right decisions that are good for the people and the planet. I'm delighted that we have them and we can tap into their you know, ideas as well and passion. And in terms of bringing people with us, because that is the tricky bit, be it me trying to say you need to lose weight or you need to eat healthier. People say, what are you preaching me? It's difficult. I haven't got enough money. If we're combining in the health angle with the sustainability angle, we reach many more people. Some people are only interested in health. Some people are only interested in sustainability. We've got a lot, but if you combine them, we have many more. And finally, a health frame around climate change sometimes flips it a bit, because again, I've spoken to a number of youngsters, and Anna can come in, but it can be quite doom and gloom. The planet is going to pots and we can't do anything. If you start to frame some of the opportunities, what we can actually do now and here, and they're good for your health tomorrow, it becomes less of a daunting task. So again, it might help us. I'm sure even more, it will help us to bring people with us. And that is the absolute necessity for anything, be it health or sustainability. So I leave it at that. I recommend the report, and I hope you will be able to endorse it so that we can disseminate it. And I hope that I can rely on you to work on the opportunities. Thank you.
Thank you, Dagmar. Are there any questions or comments from other members of the board? Jennifer.
Yeah, thank you very much, Dagmar. It's great to hear your passion about that climate action that needs to take place. It's fantastic. And obviously the way that it all coordinates together, health, climate, it's a really good report. Thank you for putting that together. But I would say that it's all about the environment that we live in and seeing how we live and work in our environment, and the things out there that we can change. You can make a real difference, I think, around active travel and all sorts of other things like that. So great work to be done, I think. Thank you.
Anyone else? Okay, well, the recommendations for this are on page 85 of the printed agenda, but if you're looking on your laptop, it's 89. There's always a difference, and they are A and B. A being to endorse the annual public health report, which Dagmar asked specifically that we should do, and then to consider the opportunities and how we can innovate our ways of working across the council. These are two really important issues. So are the recommendations agreed, A and B? Thank you. Okay, so item 7 is the ICP Care Partnership strategic priorities, and Mark has kindly agreed to present these to us.
Okay.
And I think you've got some slides as well. haven't
Yeah,
you?
I've got some slides. I think Clarissa's going to show.
Ah, we do. I think there is a problem at the moment with the is it the internet?
The internet's gone in the chamber.
So,
So Jade is trying to work out a way of around it, but at the moment I'm not able to share. I'm so sorry.
I've got copies of your slides anyway, so I don't know if others have.
shall I just talk to it?
Yes, I think so.
If the slides come
if
up.
you could describe the slides.
Okay, so it's purple. No, so as you'll know, the Integrated Care Partnership was established on the 1st of July, and the partnership, as in the ICP, it's a really important partnership because it brings together health, social care, our chairs from our health and wellbeing boards, the voluntary sector, Health Watch, and numerous health colleagues as well. And basically, one of the first things it wants to do is develop a kind of a strategy. What are the integrated care priorities across Southwest London? So they brought together a perfectly formed group, and it's been months in identifying kind of what the health and care needs are from our Southwest London population, and then really bring those together for conversation, for engagement across the stakeholder patch. In terms of looking at the assessed needs, what people did was basically looked at community views and feedback, the wider determinants of health, things like the JSNA, some of the core 20+5, all the information that we had available to us to really look at a comprehensive kind of needs assessment across Southwest London. And in that, we took lots and lots of views about what was important to people, such as access to health services, employment, mental health was a recurring theme, and also things like referral times, just everything that was really important to people. Then what we looked at across the Start Well, Live Well and Age Well domains were some of the commonalities, such as mental health, such as early years in children and young people, transition, long-term conditions, prevention, and again, mental health, which appears in all three of those domains. So when Southwest London decided to determine their priorities, it was to basically bring the group, the partners together, take some ideas and discussion pieces to the Southwest London People's Panel. And what has come out of that is actually some recommended ICP priorities. So those are 4 priorities: preventing ill health, promoting self-care and supporting people to manage their long-term conditions, supporting the health and care needs of people, children and young people, targeting mental health, and community-based support for older and frail people. So things that we absolutely know at a local level are really important to us. Very key is that actually, and I think our own chair recommended this, is that there was a 5th priority, and that was about tackling and reducing health inequalities. And that really is, I think, a framework for everything that we do. The cross-cutting areas were around equality, diversity and inclusion, championing, as Dagmar has presented, the green agenda, but also making sure that we're elevating people's voices. We've learned in COVID that actually it's not just about the delivery of services, it's actually listening to our residents as to what will work in their particular demographic, etc. So those are the recommended priorities. And from that, the board agreed that across our system, everyone was talking about workforce challenges, and that actually for the ICP to focus on year 1 would be workforce, and it identified 4 work streams: making South London a great place to work, targeting action around difficult to recruit roles, designing a future workforce. Actually, what does our future workforce look? Because it's quite different from now. And I think this, I think there's a security there, so I'll just carry on. And then supporting local people into employment. So really targeting our employment opportunities at our at our localities and at the people that need it most. I think I'm a couple of slides ahead of you there, Clarissa, but you're catching up. So I'm on slide 9 now. Next one. How's it, Jade? Slide 9, Jade. Thank you. So those are just the priorities, just so that you've seen them written down. And then the next one is just the recommended year one focus on workforce. And I think just to say on workforce, every sector is experiencing challenges in workforce. So actually really coming together might be the something that we can affect some change. Next slide, please, Jade. So finally, the Integrated Care Partnership has set out these recommended priorities and want to know whether you feel that they are appropriate. That's what, as a partnership across South West London, we should be working on, that we focus on workforce and that you agree that those areas of workforce challenge are kind of right and proper. And then any other areas that we might have missed or forgotten or that should be included in terms of the partnership priorities. Now, I'm aware that it's asked us to have a discussion. We've got limited amount of time. So if people do want to take the document away and read it and then send comments via me, I'll ensure that they get back to the ICP, but it would be good to get people's kind of views at the same time. Thank you.
Thank you, Mark. I mean, I attended the meeting of the ICP where this was discussed, and the thing that struck me was that at the beginning of the document there is a very strong reference to tackling health inequalities, but then when we came to the priorities it wasn't included, and I just felt, wow, that's, we've spent so much time not just in this meeting but right across the partnership across South West London discussing the need to address and tackle health inequalities. And so I recommended, with support from some of the other people there, that shouldn't be in the introduction and right at the beginning, but not identified as a specific priority. And I'm pleased to say there was support from a number of others, and that was accepted by the meeting. The other thing that came up was in relation to workforce. We were talking about, I think it really is important that we prioritise workforce. There's so many issues around at the moment that are affected by workforce issues. And one of the things that I felt was missing from some of the recommendations there was that we do need to address the issue that John touched on earlier on, which is, if you don't pay people, you shouldn't be surprised if you don't have a workforce. It's fairly obvious. So I challenged some of our colleagues. The NHS, we know, have already agreed to pay the London living wage. Merton has done it. And I was kind of asking our colleagues right across South West London to, as we have done with the contract that we're going to let next year, put your money where your mouth is, and let's stop having this huge level of vacancies in some of the most important jobs undertaken in our community. So I'm hoping that there will be people thinking about their own policies and taking the action that's required there. That's all I wanted to add. So be interested in the views of others. Mark's asked if they've missed anything, if there's something that you want to raise. Dagmar.
Yeah, so thank you, and thanks, Mark, for presenting. I understand a lot of effort has gone in creating that with an ICP as diverse as it is across a big footprint is a challenge. So I feel, looking at the priorities, you can't fault them. As you clearly said, Chair, we need to push. And I would say inequalities need to be embedded into each of them. We can't just siphon them off into a little bubble. It needs to be part and parcel of our approach. What I feel where more work needs to be done is now to really think who commits to do what. Yeah, because these are all laudable things, and we've all been trying to do bits of them. The idea that a system is stronger than the individual organizations, we need to push that a bit. And so for me, it's almost like orchestrating the power of an integrated care partnership to be quite clever, to say who is in the best position to do what, so that when we bundle our efforts, we get more. And I feel that's lacking. It's a bit of a samey list of laudable things. So I would send back the ask, let's do that type of work and don't shy away from it. That's one. And the other one on the workforce, couldn't agree more. I mean, it is such a basic prerequisite for any of the things we want to do. And I completely agree, I think, spot on paying them well. We as a health and well-being board can also push the health and well-being of the workforce, because that is intrinsically linked. And this health and well-being board before the pandemic had already said we wanted to put more effort into looking at our workplaces. Yeah, how our workplaces are actually supporting holistically the health and well-being of our people. And I feel as a health and well-being board, that could be quite a complementary contribution to that priority of workforce. Thank you.
Okay. Any more comments, suggestions? Brenda.
Thanks very much. Yeah, I haven't actually read through this, so I'll come back to you with it. But something that's bothered me for the last 40 odd years of my time in the health service and wherever else to do with health, primary and secondary care it needs to be sorted out, because in fact they don't work together, and that's why we have bed blocking and whatever happening to the health service, because the secondary care isn't being looked after properly. And I really think that we need to discuss how we work together and not make it look as if it's two different families. Thanks. But I'll come back with the rest of my thoughts. Thanks.
Mark, do you want to respond to that? Or maybe Si would like to, well, both of you, why don't you?
Okay, I'll just pick up on Dagmar's point about it is about action, isn't it? It's about how we translate something like this strategy into action. And I do think, just in terms of, we always talk about Merton Health and Care together, and we talk about the Health and Wellbeing Board, but there is also the Merton Partnership, where you've got the police, we've got employment organisations around the table, and actually that's something that we should probably take as a platform from this to there as well, and have that conversation about workforce, because I think that's really important. Primary and secondary care, I think, have got a history of working in silos. I do think in South West London and in Merton, we've done lots of work to try and break down those barriers. There's 16 clinical networks which are chaired between a primary and a secondary care clinician together. And that's quite powerful, because actually it breeds understanding in terms of what we can do. We've also got examples from COVID and the virtual ward, where actually we're seeing them working much better together. But then I'm going to defer to someone that's on the front line and Si, anything that we wanted to add there.
I think firstly, this is really about integration. How do we break down barriers? And when you think about primary and secondary care, it's really about secondary care and out of hospital care across health and care. When you look at flow through hospitals supporting ED, I mean, there are a number of strategic groups across the ICS and within Merton that are focused upon that. So it's a fairly complex picture, but I think the nub of it is, and it's part of the ICP priorities, it's about integration. So it's not just who does what, but how do we get people working together to do the same thing in a coordinated way? So integration is key to this with finite resources, and it's about out of hospital care working with secondary care in a meaningful, impactful way, which takes time and effort, but we've got good relationships in Merton.
I believe that people are better off in their homes, if at all possible. And so therefore, we should start working from the prevention of going into hospital. And then we can cut the hospitals, as has been happening. And we won't go into that tonight. But that would cut down some of the expenditure in terms of money and also people. And I've seen people going into hospital before you know it, they're dead, because they really don't want to be in a different place. And we don't seem to see that being in your own environment with people around you could be a better place. And we need to work on that, I think.
Well, you're responding to this specific, okay, please, yeah.
So I think every borough in South West London now will be kind of marked against the 2-hour rapid response target. So when people are in their home and they need support in their home to avoid a hospital admission, every borough now has that service in place. For Merton, I think we've also got the newly developed hospital at home service, and that's got 2 things: avoiding people going into hospital in the first place, and then getting people out of hospital with a higher level of acuity. And it's actually our GPs, our community health services, and the support of secondary care clinicians to kind of make that happen. So I think we're on a journey. But I do think we've started that journey, and we've started quite well in Merton. And perhaps that's something we bring back to a later date, because it's part of our transformation over the next year.
Thank you, Mark. John, I've seen you, but there's a big yellow hand sticking up from Karen Worthington. So just because you're in the room doesn't mean to say you get to speak before the people that aren't with us in person. Karen.
Hello, sorry, I didn't realise my hand was big and yellow, but anyway, some of what I wanted to say has already been said. I'd like to echo what Councillor Fraser said about working across boundaries. I think that's a really important part of any sort of workforce strategy, and I think we need to be innovative about how we recruit, how we share staff across organisations within health, but also across health and social care maybe as well, and thinking about things like trusted assessments so that patient experience is better, and also it's a more efficient way to work. So I feel really strongly about that, and I think also shared records becomes part of that. So that was the first thing. But the other thing I wanted to say around workforce is when we were talking about new roles, we need to do work with the public around communication. So and also actually amongst ourselves, so that we all understand what the new roles are and how they can best be used to serve our population. We have had feedback in primary care actually that some patients don't fully understand what all of our new roles within our primary healthcare teams can actually offer people. So I think however we develop our workforce, we need to ensure that the public have a good understanding of who does what, and how we can work together really. Thank you.
Thank you. John, do you want to?
I'll be very quick. I think it was also a really good point you've raised as well, Councillor Fraser, about silo working between primary and secondary care, but I could also include adult social care within that as well, because there's also silo working in there as well. We work very well together in Merton, but we are still distinct organisations. And to solve the workforce challenges, as Dr. Worthington's just said, we need to look at integration. That's the only way, in my view, that we're going to be able to solve some of the challenges we have. Now, my colleagues here have heard me for 5 years speaking about occupational therapists. We have occupational therapists in my teams, in hospitals, in GPs, in mental health. We've got them all over the place. The systems don't speak to each other. The assessment, one will do an assessment in the hospital, that doesn't filter through to my teams or through to GPs. And if we got that right and move that across all of our other areas, it could have a huge impact for us. So for me, that's one of the things that we've got to focus on the next year or two.
So are you declaring this as one of your New Year's resolutions?
My New Year resolution, and it goes in my title, Integrated Care.
We'll hold your feet to the fire on that one, John, and we'll expect a report back in a few months that this is really starting to move. So, and I think that touches on Dagmar's point earlier on about, what are we actually doing? Are we talking or are we getting things done? I sense that there is a desire to get things done right across the different organisations that make up the partnership. So let's get cracking. Anything else that people would like to say about the integrated care partnership priorities? Keith.
Thank you, Chair. So just to raise very briefly, in the context of the conversation about siloed working, just before Christmas, the NHS issued guidance to ICBs on joint forward plans, which are required in draft by March and in final version by June of this year. And those plans at their core are about how the different NHS organisations will work together to deliver healthcare to population that they serve, and it has a link to the integrated care partnership strategy. But I think so that will come back to the Health and Wellbeing Board probably in March, but we just need to work out some of the detail of that. But that will be a further opportunity, I think, to have that conversation about how we create more integration between the different parts of the system within health, but across social care as well and across wider council functions. So it's a discussion that we'll be able to return to, Chair.
Thank you. Are there any other? Si, you look like you wanted to say something there, and no, you were stopping yourself. But I don't think you're the sort of person that would stop yourself. You just go ahead and do it, and why not? The one thing that when I was listening to the discussion earlier on about the blockages, and Brenda raised this issue. What I've been sort of hearing and reading lately is there was a director of adult social care who flagged up the number of hospital beds that have disappeared over a period of time, and I think some of the doctors' representative groups have been drawing attention to this because we all know that if you run any kind of machine or organization at red hot for an extended period of time, then you shouldn't be surprised if things start to go wrong and it's not able to achieve its objectives. And I think that's an important issue as well. And I mean, this we're talking about government policy over an extended period of time, but have we gone too far? And is that part of the problem? Because we're looking around, we're thrashing about, looking for solutions, and that's at the heart of it as well. And I hope we won't lose sight of that. I'm certainly going to be raising it when I get the opportunity to do so, because I think it has to be part of the mix. Mark, do you want to?
Yeah, I don't disagree. I do agree. I think also just in terms of hospital, some of the pressures that we have seen of late, and that they have been extremely pressured, and we've been on daily calls with our colleagues around this table. And it has been about workforce. It has been about the impact of things like Brexit, the lack of staff. And actually that may well be having an impact on number of beds as well, because if you haven't got the staff, you can't run the beds, you can't run the wards. So actually there's a real knock-on effect to some of the workforce challenges. And we're seeing that now. We want to start planning for next year to make sure that we're not under that pressurized environment going forward.
Okay. Does anyone else want to add anything to this discussion? Okay, well, the recommendations before us are on the supplementary agenda, and they are recommendations A and B, and it's on the laptop, page 3 of the 24 pages, and it is to seek the views of Merton Health and Wellbeing Board on the recommended priorities, and we've given some instant reaction, but Mark has extended the invitation for people to get in touch if there are things that occur at a later stage, and then to seek feedback on any key workforce challenges. And I think we've already done that. So can I suggest we adopt these recommendations? Is that agreed? Thank you. So that brings us on to the, forgive me, to the final item on the agenda, and that's Adult Social Care Discharge Fund. And Graham, you're going to lead on this.
Thank you. This is actually an example of what's wrong, as well as how we can turn what's wrong in terms of an approach into something that's actually delivering and is delivering on some of the integrated working ambitions that we have. So this is a £500 million adult social care discharge grant that was first mooted back in September last year, but wasn't until late November when the government issued the guidance around what we could use it for, which left us with an incredibly short period of time in which to invest the sums you can see on that slide there. So in total for Merton, it was 1.474 million. That had to be invested in plans submitted by the 16th of December. It was to focus on making sure that we didn't spend it on existing commitments, and it was to maximize reductions in delayed discharges with a focus on the home first approach. The reason why it's only now coming to this Health and Wellbeing Board after its submission date is, like most authorities, there wasn't sufficient time to bring it to a meeting of the Health and Wellbeing Board. There wasn't a Health and Wellbeing Board meeting before the 16th of December. So we reluctantly had to do what, as I say, the vast majority of authorities around the country did, which was to go to their Health and Wellbeing Board chair and seek their approval, alongside obviously it being signed off by the chief exec of both the local authority and the ICB. Despite the incredibly short timescale in which to pull a plan together, you can see on we'll skip the metrics and so on. Those are fairly boring things and are creating all sorts of havoc for us because they're required fortnightly. And given that we've already had winter monies that we're reporting on separately, and then there's been a subsequent more recent 200 million that has been given to the ICB to purchase step down beds, etc. Trying to keep track of this and also report on outcomes is quite a challenge. And I feel for the ICB colleagues who are expected to do daily reporting on the use of the 200 million fund once that's invested. Why I think we have turned it into something more positive is because as a collective involving a whole range of partners, we've been able to invest the 1.4 million into things that I think have a broad range, try and meet a broad range of needs. One of the investments has been in the voluntary sector in terms of Age UK and Merton Carers to provide in-reach activity, particularly in St George's, so that their expertise in reassuring families and carers as patients in hospital, and also ward staff in terms of what's available out there and what supports are available to people who are discharged, alongside Age UK services to support people. And that's built really on the existing services that were already commissioned about from the Dementia Hub, for example. The Dementia Hub have an in-reach worker that seeks to ensure that if somebody is part of their admission and prior to discharge is diagnosed with dementia, that they link those people up with the support and services that are available in the community. So it not only helps to facilitate a discharge, but also reduce the likelihood of a readmission. The other things that are in there are the support to rough sleepers. There's additional temporary accommodation capacity for discharges that's more accessible accommodation. the support at home in terms of twilight nursing and overnight care. There are more beds within this fund in terms of the bed bureau, neuro rehab beds, etc. So those are important. But what we wanted to do was to reflect that balance that we want to strike going forward. About this is about maintaining people's independence at home and enabling people to quickly go to home without having to go to a bed-based service on the way, unless it's absolutely necessary for their rehab. We've also included in here some of the funding for the free 4-week telecare offer. And there's also an in-reach drug and alcohol service. So there's quite a wide variety of schemes that are really now beginning to motor and operate. And in terms of, is it working? I think it's having an impact. Is it enough in terms of reducing all the pressures on St. George's in particular? No, but if it wasn't in place, the pressures would be even greater. And I think the discussions tonight have highlighted a number of the challenges about how you spend large sums of money very quickly and have to spend them by the end of March. And it's a very short-termism approach. But as I say, what we've tried to do is test some of the integrated ways of working, more flexible working amongst staff who are involved in hospital in-reach and in supporting hospitals. So there have been staff in the CLCH that have been at front of house in the hospitals trying to divert admissions, as well as all the voluntary sector, as well as our social workers, etc., etc. So in that sense, that breaking down the barriers, building relationships is going to be a really important spin-off from this. And part of the exercise at the end of March is going to be evaluating all these schemes and seeing which ones have actually delivered really good outcomes, and we want to carry on and continue to invest in them and develop them further. So I'll pause there, but I think it's a demonstration of trying to make some good outcomes from a very rushed process. And I would, I think, echo some of the comments in this room about come the spring, we need to start planning for next winter. And we need to be looking, as I say, at the things that have worked and the things that we can build on and develop further. And integrated working will inevitably help our response in the future. And hopefully the sums of money that may then come next winter will have a much more flexible use, rather than you have to spend it on placements or hospital beds, etc., etc. So that we can really promote that shift into community capacity, not just in adult social care, but in community health, so that people don't need to go into hospital as often. And if they are in hospital, there's a whole range of supports and services out there that can enable a speedier discharge. Thank you.
Thank you, Graham. I think before inviting general comment, I'll offer the opportunity to my NHS colleagues to tell us how it's been for them.
Okay, I'll go first. I think Graham, when he described, actually it was a collective. I do think actually all our teams came together brilliantly. Yeah, because within a day or two, we suddenly had like 13 schemes that we could work up and work through. So I think congratulations to all the staff members that were involved in it, because Graham again is absolutely right. You know, you get like 2 weeks to come up with a plan and spend this money, and we do need to feed back that that's not a productive way of doing things. We need much more time planning so that actually we can make sure the investment. I think the monitoring of these will be essential, and I'll let Si speak in a minute. But just one thing that I would say, and it's building on what Councillor Fraser said, what we are getting feedback from is where people are crossing sectors, so CLCH therapist going into the acute trust, a GP going into the acute trust, a social worker going into the acute trust, we are seeing that that is a real benefit, because suddenly they get to know what each other do. And, you know, the social worker can say, I can take that person out. That's okay. I can get a care package. And that's some of the power that we need to build upon. It has been extremely pressured, though, and our hospitals remain kind of with strikes, et cetera, kind of on red alert. Sorry.
You know, I would echo what Mark has said. I mean, there's been immense pressure over the last 2 months. And whilst the funding is welcomed, I think it's really about how we start to work more proactively and plan ahead for next winter. And I think we've got ideas around what the potential benefits and opportunities might be. We're realising, for example, what primary care can offer through things like GP and Reach, and how primary care networks can work with partners. But it is really about how we start to forward plan more effectively, rather than rushing to sort of spend the money in inverting commas. It's really about how we start to plan. I think that's the key sort of take home point for me, really, that we need to start to plan ahead.
Thank you. So are there any questions? Councillor Fraser.
Mine isn't a question.
Or comments?
Mine is actually, well, I can't understand how you managed to break that small amount of money down to the last penny, it looks like. And I actually appreciate all of what you've done, because I don't think I could even manage this. It's a lot of sleepless counting out and making sure you use every penny. I think we need to talk to the government, whichever government that comes in after us, that this is this is like an icing, I don't know what it is really. It's just a drop in the ocean to deal with those type of situations. And so I'm really, I don't know, appreciate your work, I should say, for doing so much work with so little.
Well, Lou, I'd love to take all the gratitude. It is actually Graham and my team and John, and it has been a completely collective piece of work driven by Graham, I have to say, and Sandy and my team. So yeah, thank you.
I think what Councillor Fraser is saying on behalf of the local community, we thank all of you, and please do take that back to your colleagues and your teams and tell them that we recognise just how difficult things have been, and we really are grateful for all the effort that's gone into dealing with this and collaboration. Jennifer. Okay. Anyone else want to? Sorry, I'm terrible with names.
Brian.
Brian, forgive me.
This may be a stupid question, but I mean, what was the baseline that was used upon which success was actually measured? I mean, it's a pretty obvious thing. Presumably, St George's had a certain level of people they wanted to get out. I mean, I don't know how you actually quantify this, but I'm just interested, really. You know, it's kind of a bit subjective, it seems to me. Like it's an input measure, really. I'm just wondering how we can turn it into some kind of output measure on the assumption it continues.
Best place to answer that, is it Mark or Graham?
Shall I have a go first?
Okay.
It's a very good question, because we have spent a lot of time looking at how we capture the outcomes of each individual scheme, and often it's schemes playing a part in an overall jigsaw of there is a discharge. There's a discharge from hospital, so there's one less person who's taking up a bed that then frees up a bed for somebody else to go into. And often there needs to be a number of different parts of that jigsaw to make that discharge possible. There are daily calls in terms of reviewing everybody who is potentially ready for discharge or is actually ready for discharge, and the amount of work that goes in from across health and social care professions is phenomenal in tracking that and trying to make sure that people leave hospital as speedily as possible but safely, and that they're going to the right place, primarily trying to keep people return people to their own home. So this concept of we need to buy more beds, people have beds, it's in their own home. So that's the place we need to get people back to as often as possible. So we're really measuring, are we reducing the number of delays in hospital, the length of stays in hospital, people's experience of that as well. So there are some anecdotal, there are some numbers, but in terms of reporting on them, it's very difficult to say, well, it's because of this one scheme. So do you attribute that discharge to the fact that reablement have been able to take 4 people out of hospital at the weekend, for example? 24/7 working has had a huge impact, and we're able to discharge people 7 days a week. So we have to collate all of that information to see whether we think it's having an impact, and then ultimately, is it making the life of the hospital, people's access to community health and social care more effective? So when I say I think it's working, it's based on that sort of, but the huge pressures are on the workforce, because if you are struggling to recruit, struggling to retain people, and you have vacancies in your workforce, then it means there's more work falling on the people who are in the permanent posts actually in that workplace. So in terms of Dagmar's point about healthy places of work, if we can solve some of the workforce issues, it will make it a better place for people to work, and a more enjoyable and more manageable place for people to work, instead of being under huge pressure day in, day out. And that's experienced by health and social care staff. So, and in winter time, it used to be that you could think, well, come the spring, people can take a breath, but it doesn't seem to happen like that any longer. It's almost like winter is now, in terms of the demand and pressures, is with us all year round. So we have to find ways of addressing that. Sorry, that was a long answer.
Do you want to add anything to that?
I'd probably say that the metrics are really blunt, aren't they? Because it's bed days, it's number of discharges. We can measure readmission, so has it been successful? I think one of the things that we need to develop is actually, what's the patient experience? Actually, where's the patient voice? Was it a good experience for them to be rapidly discharged, etc., into this new world of virtual wards, etc.? So I think we're, again, you know, as I said it before, we're on a journey about how we measure the success of some of these.
I hope that answers the question, Brian. Good. Okay, so we have a recommendation which is on page 129 of the pack, or 134 on your laptops, and it is to ratify the submission of the Adult Social Care Discharge Fund to NHS England by the deadline of the 16th of December. Graham's explained the circumstances in which we come to you after the event, but needs must, and as chair I felt it was entirely appropriate that I agreed this in an emergency situation in order that we could get moving and get something done in this crisis. So is that recommendation agreed? Thank you. Well, that brings our meeting to a close, and I think I was scheduled to finish at 15 minutes past 8. It's 13 minutes past 8. So thank you for your discipline, but also thank you for your contribution, the questions and the answers, and take the rest of the evening off.